dopamine levels. It has a minimal effect on the norepinephrine. You should never double up on a Wellbutrin dose. If a dose is missed, it needs to be taken in divided doses to decrease the risk of seizures. It is similar to amphetamines. It suppresses the appetite. Smoking cessation, well tolerated if difficulty with orthostatic hypotension. Increased seizure risk, start with no more than 75 milligrams 3 times a day with a max of 150 3 times a day. There's very few anticholinergic and no cardiovascular side effects. Okay. Trazodone, this agent has moderate selective blockade of serotonin receptors, therefore increasing the amount of the neurotransmitter available for impulse transmission. This agent is usually used with another antidepressant and may be used for insomnia. Sedation may be an issue, therefore it should be indicated for a client who has insomnia caused by an SSRI. Advise the client to take it at bedtime. Priapism, and do you guys remember what priapism was? Hello? Anybody out there?
Erection.
Do what?
Inability to have an erection.
No.
No.
It has to do with an erection, but it's not an inability to have one.
A prolonged.
A prolonged erection lasting more than 4 hours. It's a serious side effect of trazodone, and clients should be instructed to seek medical attention immediately if that occurs. Other side effects of trazodone are sedation, orthostatic hypotension, nausea, vomiting, and there's no anticholinergic side effects. It should be taken after meals to minimize nausea and dizziness. And mirtazapine or Remeron increases the release of serotonin and norepinephrine, thereby increasing the amount of these neurotransmitters available for impulse transmission. The therapeutic effects can occur sooner with less sexual dysfunction than with SSRIs. This medication is generally well tolerated, and adverse effects include sleepiness that can be exacerbated by other central nervous system depressions, weight gain, and cholesterol. Okay. Uses of your atypical antipsychotics. Uses, depression, an alternative to your SSRIs for people who can't tolerate the sexual side effects, aids to quit smoking, diabetic peripheral neuropathy, and neuropathic pain. Side effects, we went over them. If they have anticholinergic side effects, I think we've gone over that enough. I'm not repeating it again, but down in the notes, it tells you what the anticholinergic side effects are and what the side effects are of the different drugs. Teaching may take up to 4 weeks to see results. Use caution when driving. Don't discontinue abruptly. Ways to control dry mouth. Don't drink alcohol. Don't take other medications without the physician's approval. Monitor kidney and liver function, and take with food to decrease GI effects. Electroconvulsive therapy. We went over this a little bit yesterday. It's a non-pharmacological therapy. It artificially induces a seizure, and the theory on the effectiveness is that it enhances the effects of the neurotransmitters of serotonin and dopamine. Indications would be severe depression, non-responsive to pharmacological treatment, schizophrenic patients who don't respond to neuroleptic medications, and acute mania episodes such as rapid cycling destructive behavior, because these symptoms don't respond well to lithium. Contraindications to electroconvulsive therapy are a recent MI, a history of a stroke, intracranial mass or lesion, developmental disorders, chemical dependence, or mild situational depression. Robenal is a medication that they give if you're going to have ECT, and it's given 30 minutes before the procedure to dry up their secretions. Then they are giving Brevital as an anesthetic and succinylcholine as a muscle relaxant. Nursing care, if somebody receives ECT, the doctor would perform a history and physical prior to treatment. They should be NPO for 8 to 12 hours before. If the client is declared incompetent to provide consent, then their guardian would need to provide consent. You would need baseline vitals, oxygen, and IV and EKG monitor. Post-procedure, upon awakening, they may be in a post-ictal state, like someone who just had a seizure. The client is usually returned back to their unit within 30 to 60 minutes once they're awake and stable. Memory loss may persist for weeks, and the nursing actions are to monitor the client, reorient, provide a safe environment, assist with memory, administer analgesics and/or antiemetics, and do not feed them until their gag reflex returns. Alternate therapies. So you don't want to use ECT, you don't want to use meds, or maybe you want an adjunct to the meds. You can use light therapy. It's used primarily for people that have the seasonal affective disorder. Exposure of the face to the light 30 minutes a day, either once or in 2 15-minute increments, seems to help. TMS is a new therapy used to treat depression that uses electromagnetic stimulation to the brain. And VNS, or a vagus nerve stimulator, is an implanted device that stimulates the vagus nerve, and it's used to treat depression. Okay.
Where did they implant it?
What, the vagus nerve stimulator?
Yes.
It's usually implanted somewhere close to the vagus nerve. The vagus nerve goes down through your abdomen.
Okay.
Okay, bipolar disorder. It's a mood disorder that affects approximately 2 million people in the United States. It usually emerges in late adolescence or early adulthood, and it's difficult to diagnose in children because the symptoms overlap other mental illnesses such as ADHD or oppositional defiant disorder. It's also called manic depressive disorder. The severity of symptoms can range from mild to severe, and the depressive period usually lasts longer than the manic phase, and treatment and care client depends on what state the client is in. Not state like in Maryland or West Virginia, but state as in depressive or manic. Risk factors, biochemical imbalance, family genetics. A child has a 25% risk if one parent has it, and 50 to 75% risk if both parents have it. More common in identical twins, and it can be seen in cases of adoption. Women are more likely to develop it. Men are more manic, have more time in the hospital, and have more alcohol and drug abuse. Environmental stress. Stress, loss, poverty, social isolation can occur in upper class, creative individuals, highly educated, and professional individuals. Psychological influences, inadequate coping, and biological factors such as excess of your neurotransmitters of norepinephrine, serotonin, and dopamine, increased intracellular sodium and calcium, neurotransmitter supersensitive to the transmission of the impulses, and defective feedback system in the limbics, as well as hypothyroidism. It can be precipitated by stress, major loss, major illnesses, financial trouble, treatment for depression, sleep deprivation, hypothyroidism, and substance abuse. There are several phases of bipolar. You can have your acute phase, where there's acute mania, hospitalization may be required, and the goal is to prevent self-harm and safety. Prevent self-harm and have the client be safe. The continuation phase, there's a remission of symptoms. The goal is to prevent relapse through education, medication, adherence, and psychotherapy. And then maintenance is an increased ability to function, continuation of treatment, and the goal is to prevent future manic episodes. There is bipolar 1, where you have at least one episode of mania alternating with major depression, and bipolar 2, where there's one or more episodes of hypomania alternating with major depressive episodes. Mania is an excessive high. It's an abnormally elevated mood. It's excessive or frenzied motor activity, impairment in jobs, social activities, and relationships, usually requires hospitalization to prevent harm to self and others, and they may exhibit psychotic symptoms. Symptoms of mania: significant decrease in the appetite, neglected ADLs of nutrition and hydration, unlimited energy, hyperactive can lead to exhaustion, grandiose and persecutory delusions, impairment in social and occupational functioning, attention-seeking behavior, flashy dress, makeup, and inappropriate behavior, and high and unstable affect. Other symptoms: adolescents may engage in risky or reckless behavior. Others often will deny that anything's wrong and dislikes interference and is intolerant of criticism. An increase in talking and activities and grandiose view of self and abilities. Hypomania is a less severe episode of mania that usually lasts at least 4 days. It exhibits 3 to 4 of the symptoms of mania, and hospitalization is not usually required. This is usually the behavior that is seen with bipolar. Then you can have mixed episode, where you have an episode of a manic mood and a depressive mood simultaneously. You have a marked impairment of functioning, and you require hospitalization. This is also behavior seen with bipolar. Rapid cycling is where you have 4 or more episodes of mania within a year. Complications of mania are physical exhaustion, suicide, and death. They can ignore sleep, hydration, and nutrition for months, as long as their manic episode lasts. Depression. They experience the same symptoms. Yes.
Okay, death and suicide are 2 separate things. Would death be, when it says because they can ignore sleep, hydration, nutrition, meaning it would be the cause of death, versus suicide where they kill themselves?
Correct.
Okay. That was all. I was just wanting to make sure.
Depression. Same symptoms as major depressive disorder. Screening tool is mood disorders questionnaire. Your nursing diagnoses: risk for injury, deficit in nutrition, less than body requirements, sleep pattern disturbance, and self-care deficits. Interventions. You want to remove any hazardous objects from the environment, monitor the client regularly for suicidal thoughts, intentions, and escalating behavior. You want to establish a calm environment. Decrease stimulation without isolating the client if possible. Be aware of noise, music, television, other clients, all of which can lead to an escalation of the client's behavior. In certain cases, seclusion can be the only way to decrease stimulation for the client. You want to provide simple and direct explanations for routine procedures. Provide the client, or protect the client, from poor judgment and impulse behavior, such as giving money away and sexual indiscretions. Maintenance of self-care needs and supervised choice of clothes. Be consistent among staff members. Encourage the client to ventilate their feelings. Use calm, slow interactions, and help the client focus on one topic during the conversation. Ignore or distract the client from grandiose thinking. Present reality to the client, but do not argue with the client. Limit group activities and assess the client's tolerance level. Provide physical activities and outlets for tension. Avoid competitive games. Provide gross motor activities such as walking. Provide structured activities or one-on-one activities. Do not involve the client in activities that last a long time or that require a high level of concentration. And implement frequent rest periods. You want to use a calm, matter-of-fact, specific approach. Give concise explanations. Provide for consistency with expectations and limit setting. Avoid power struggles. Listen to and act on legitimate client grievances and reinforce non-manipulative behaviors. You want to provide portable, nutritious food because the client may not be able to sit down to eat. They might be on a manic phase and they're not going to be able to take the time to sit down. They think they have to go. So you want something portable that they can just put in their mouth and go. You want to monitor their sleep, restrict their caffeine. You want to assess them closely for fatigue. Provide frequent rest periods. Use comfort measures to promote sleep, and provide a private room if necessary or possible. Administer hypnotic or sedative medication as prescribed. Medications for bipolar. You want to use a mood stabilizing medication. Lithium is your most common. It's used for bipolar or major depression to manage and moderate to extreme shifts in emotions. Okay. Lithium is the drug of choice for bipolar disorder. It controls your manic episode. It's used for long-term treatment. It has a drug level that has to be obtained from blood, and it takes 2 to 3 weeks for the drug to be fully effective. Side effects of lithium. You can read those for yourself. Lithium. Remember we said yesterday with lithium, if the sodium level is increased, the excretion of lithium is increased. The sodium level is decreased or sodium is lost, lithium is reabsorbed by the kidneys and the risk for toxicity increases. Your initial treatment level of lithium is 0.8 to 1.4. Your maintenance level is 0.4 to 1, and your toxicity level is over 1.5. You want to make sure you're monitoring the patient's renal level or renal function. The exact action of lithium is not known, but it is known to inhibit the release of norepinephrine and dopamine. There is a direct relationship between sodium intake and lithium excretion. You can see increased lithium levels with decreased sodium intake, diuretics, and decreased renal function. You want to make sure that you are drawing a lithium level 12 hours after the last dose was given. You want to monitor the serum levels every 1 to 3 days when you're just starting therapy, and every 2 to 3 months thereafter. If their lithium level is 1.4 or greater, you're going to hold their lithium. And I told you toxicity is 1.5, but you don't want to wait till they get toxic, so you start holding it at 1.4. Older adult clients are at an increased risk for toxicity and require more frequent monitoring. Signs of toxicity. You need to know these signs. Early toxicity is when they are less than 1.5. Nausea and vomiting, thirst, polyuria, slurred speech, and muscle weakness. You want to hold the med first and then notify the doctor. You're not going to tell the patient to notify the doctor, because if they can't get a hold of the doctor, you're going to keep taking the medicine. So the first thing is hold the med, then call the doctor. In advanced toxicity, their level is 1.5 to 2. They have sedation or confusion, tremor, nausea, vomiting, and diarrhea. You want to hold the med, notify the doctor, and give them IV fluids to promote excretion of the lithium. And in severe toxicity, where their level is 2 to 2.5, you're going to do gastric lavage, charcoal administration, and promote the rate of excretion and possibly hemodialysis. You should avoid pregnancy while you're on lithium. Avoid driving until you know how it's going to affect you. If fever, vomiting, or diarrhea occur, that could be a sign of sodium loss. You need to notify the physician. Consult the doctor before taking any over-the-counter meds. Non-steroidal anti-inflammatories, such as Motrin and Naproxen, will increase the renal absorption of lithium, leading to toxicity. They should have a weight check every 3 months. Avoid caffeine because of the diuretic effect. Take their lithium as prescribed. It must be administered in 2 to 3 doses daily due to its short half-life. Taking it with food will decrease GI distress. Take the missed dose as soon as you remember, unless within 2 hours of the next dose, or within 6 hours if you're taking extended release. Encourage the client to adhere to their laboratory appointments to monitor their lithium levels. Provide nutritional counseling and stress the importance of adequate fluid, 2 to 3 liters a day, and adequate sodium intake. Any questions on lithium? Okay. These next 3 drugs, they're called mood stabilizing medications. They're anti-epileptic drugs or anti-seizure medications. They should not be used during pregnancy. Their uses are for bipolar, relapse of bipolar, mixed mania, and rapid cycling bipolar. They are seizure medications and they are given for seizures, but this is an adjuvant use of them. Okay. Side effects of these meds: nausea and vomiting, indigestion, headache, fatigue, abdominal pain, jaundice, pancreatitis, thrombocytopenia, double or blurred vision. Other meds that may be used in bipolar: antipsychotics during their psychotic episodes of Zyprexa, Risperidol, Seroquel, Geodon, and Abilify. Those are your atypical antipsychotics, right? Other meds that you might see a bipolar patient on are your anxiolytics that will treat your acute mania and agitation, such as Klonopin and Ativan. Antidepressants, which will treat your depressive phase, prescribed as a mood stabilizer to rebound the mania, such as Wellbutrin or Zoloft. Key points: management of bipolar, activity, disruption on the unit and medication therapy, and suicide assessment. Make sure you know about postpartum depression, electroconvulsive therapy, and that it causes temporary memory loss. Make sure you know the action, the side effects, and how long till you see results in your antidepressants. Make sure you know about lithium, your administration, your levels, toxicity, treatment, and foods and your MAOIs. And that, my friends, was mood. Now we are caught up. Next Monday, we have a test. And on that test, if any of you haven't looked, that test is open from 7, I believe, until 5. Let me just take a look. Yes, it's open from 5 a.m. to 5 p.m. Okay. Those of you who are new to 114, Maggie, Crystal, and Faye, you need to do the onboarding. I sent you the information. None of you have done it yet. It needs to be done before you can take the test, and it has to have time to process. So if you don't take it, you go in 5 o'clock Monday morning, think you're going to take it, then you're not going to be able to take the test on Monday. You need to get it done as soon as possible so that it has time to process before your test date. All right. What questions do you guys have for me? I know you have some. No questions? Everybody get 100 on the test on Monday?
I think we're all just trying to process everything that just happened.
Yep. That's psych for you.
Things are like starting to sink in, but I'm like, wait, I need to look at that again.
Okay, Sam says her mic's not working. She wants to know, do you need to focus on meds for the exam? So let me just go here and go to content. Okay, so you need to know about protective custody, trusting environment, psychologists, burnout, schizophrenia, patients' rights, healthy reality, personal boundaries, touch, malpractice, crisis, HIPAA, nurse-client relationship, voluntary commitment, involuntary admissions, effective communications, therapeutic communication, coping strategy, statements of concerns, many mental, cognitive impairment, side effects of meds, hallucinations, anhedonia, neoplasms, electroconvulsive therapy. There's 3 drug problems, there's 5 short answer, and there's 7 select all that apply. So the answer to your question would be yes. And yes, that's the blueprint. And I just opened it for you, so it's open.
So I have a question. You didn't mention Maslow hierarchy of needs. We still need to know that.
You
right?
always need to know Maslow.
Okay.
Always, always, always. You can't do anything without Maslow. Just because I don't mention it doesn't mean it's not there.
Yeah, that's true.
And you know that anything that has been covered in 111, 112, and 113 is still open game in 114. Okay. We've got a couple minutes here. Anybody want to see a test? Sorry. I'm so bad. Would you guys like to know what the fill in the blanks are?
Yes, please.
Sure.
I'll take anything that you give.
That's a very good answer. So there's going to be a drug problem where you have to take a patient's weight and convert it to kilograms and figure out safe doses. And then there's a drug problem where you have to take a patient's weight and figure out the appropriate dose and the amount to be administered. And then there's an IV calculation, and you have to figure out the drip factor per minute. You need to know, this is a given. You need to know the extrapyramidal symptoms. What are they? What are they? Number 1.
Pseudo Parkinson.
That's not number 1. Number 1 is acute dystonia.
They have
Number
to
2 is pseudo Parkinson's. Number 3 is akathisia.
Akathisia.
Number 4 is what?
Dyskinesia.
Tardive dyskinesia.
Tardive.
Number 4 is always tardive dyskinesia because that's the last one that happens.
So they,
Acute dystonia is the first one that happens. The 2 in the middle.
But
They
they
can
have to
happen
be
in-
in that order. Like,
Didn't I just say number 1, number 2, number 3, number 4?
okay.
That's the order they happen in, so that's the order you should learn them in. So acute dystonia is number 1, akaphasia is number 2, pseudoparkinson's number 3, tardive dyskinesia is number 4. The order they happen in. You need to know how to treat your extrapyramidal symptoms. You need to know what you need to watch with your MAOIs. What do you need to watch with MAOIs?
What you eat and drink.
Okay, so I need more specifics.
Age,
Nothing with
and
tyrosine
wine.
in it.
No cheese, no
Foods
water.
with tyramine in it. So if I ask you 2 foods to avoid, you need to be able to name me foods to avoid. And don't put foods with tyramine in them. I want actual foods. You have to list cholinergic side effects, and you're going to have to list both typical and atypical antipsychotic meds. Those are your fill in the blanks. A lot of mental health is about statements that you're going to say, things you're going to say to the patient, therapeutic communication, establishing trust. So when you're studying for this test, make sure that you are incorporating those type of things into your studying.
What do you mean by the least offensive of statements?
Rachel, you ask me that every time. What do I mean? I give you statements and you have to pick the least
Okay.
offensive.
Okay.
I give you
and
statements, you have to pick the most. I mean, I'm not going to give you the question. That's the only way I can
just
give
didn't
you
know
a
if
hint.
that's what you meant, like out of multiple, if you picked like which one is
Uh-huh.
the least offensive. Okay.
Yeah. How should you touch a client that is a psychiatric client?
Make sure they see you coming before you touch them.
Like you don't touch them?
Don't touch him.
You don't touch them.
Don't touch him.
There are instances where you can touch. We talked today about catatonia. We talked about using therapeutic touch. Back last Tuesday, we talked about that. So when you're talking about psychiatric clients and mental health clients, there are times when you're going to touch them. So you can't say that you would never touch them, but you're not going to go up and hug and kiss them either, right?
Right.
Mhm.
So as the nurse, you need to determine when is it appropriate to touch a client. Make sure you know the phases of the nurse-client relationship. You remember the phases of the nurse-client relationship? What's the first one?
Orientation phase.
Orientation. What's the next one?
Working phase.
What's the third one?
Termination
Term-
phase.
Termination.
Okay? So if you are involved with the client in developing self-care skills, would you be orientation, working, or termination?
Did you say developing?
That's what I said.
Wouldn't that be considered working?
It is
Because you're
working.
trying to develop. Yeah.
Yep.
Yeah.
Do you guys know what the mini mental status exam is?
No.
Is it the G something?
Isn't it a cognition test for the elderly?
This is a mini mental status exam. You ask what is the year, season, day, date, and month. And they can get a possibility of five. Where are we now? State, county, town, city, hospital, floor. They can get a possibility of 5. You name 3 unrelated objects clearly and slowly. You ask the patient to name all 3. Patient's response is used for scoring. Examiner repeats them until the patient can learn them all if possible. Then you count backwards from 100 by 7s. If they can't do that, you ask them to spell the word world backwards. And then you say, earlier I told you 3 things. Can you tell me what those were? Show the patient 2 simple objects like a wristwatch and a pencil and ask him to name them. Repeat the phrase, no ifs, ands, or buts. Take the patient, give them a piece of paper. They take the paper in your right hand, fold it in half and put it on the floor and see if they can do that. See if they can follow your directions. Please read this and do what it says. And you give them a piece of paper that says, close your eyes. You tell them to make up and write a sentence about anything. The sentence must contain a noun and a verb. And then you tell them to copy this picture. And then you score them according to that. So if they get 24 or above, well, that's on a single cutoff, never mind. Your range is above 25 is decreased odds of dementia. That's your range. On education, below a 24 would be abnormal for somebody with a college education. And on severity, 24 to 30 means no cognitive impairment. And then there's other interpretation down here. You can print this off and have them name objects, memory. I mean, you can use this as a score sheet. This is the Montreal Cognitive Assessment. This is part of the Montreal Cognitive Assessment. And that's part of the Montreal Cognitive Assessment. The only one that I've ever used in a nursing home is the mini mental status exam. Okay. So you need to know what that exam is asking. What is its kind of
Purpose?
proponent, the component that focuses on the way a person experiences reality. What are you at? What is that? What is that? How somebody deals with reality and what their experience of reality is. What is the word for that? You ever heard of perception? You guys all look like deers in the headlights. Are we awake? I know, Sam. Okay, if you guys aren't going to answer me, I'm not asking you any more questions. You do need to know about antidepressants and antipsychotics. You do need to know about electroconvulsive therapy. And there is a question about IVs and the care of IVs that comes from that PowerPoint that's in D2L that I showed you. All right, well, those of you who have clinical tonight, I hope you have a good time in clinical. Be safe. The roads here are bare and dry, so you should be fine. Those of you who have clinical tomorrow morning, be safe. Tomorrow evening at Brook Lane, let me know how it goes. And those of you who have clinical on Thursday at War and at Williamsport. And I will look for test grades next Monday morning. It will open at 5. It will close at 5 p.m. Please make sure that you are giving yourself enough time. If you have extended test taking time, don't log in a half hour before it ends and think you're going to get your time, because you're not.
You said you, what's this called? You have the blueprint now. I'm trying to find it, and what tab would it be at?
It's there. It's under content. Just scroll down the page on content.
It's still 50 questions, 1 hour.
I can't find it either, Vin Marie.
'Cause I like Control F and blueprint. Like,
Oh, you guys.
Look under lab values. It's not like in a separate blueprint section.
It's all the way at
It's-
the bottom in content. I mean, not at the way bottom, but it's like